that. We're trying to have some technical difficulties. Okay, so we're gonna go ahead and get started with our June.
Hey, everyone, we're gonna get started. Yeah, I got loud.
Yeah, there you go. So I usually do too. Okay, so we're gonna get started. Sorry, we're a few minutes late. Was dealing with some tech issues. Sorry, there was. Oh, I could hear a little background. Okay. Do you hear that? Like feedback. Okay. We're gonna do roll call real quick. We're gonna skip the video and do it right after the break, just because it takes a little bit of time to set it up. So we'll get rolling here. Do you hear that? Well, I'll deal with it when we're doing roll call. Sorry, I have a little bit of feedback. I think there's maybe a mic issue. Kyle is gonna do roll call for me. Kyle, do you mind doing that?
I'm ready. All right. Talee Clark. Sean Fulton. Katie Stafford Cunningham.
Here.
Laura Fife.
Here.
Kate Barrow.
Here.
Kim Dodson.
Here.
Ann Titus.
Here.
Jim Wiltz. Here. Lexi Westerfield.
Here.
Melissa Keys. Carrie Lee. Derek Nord. Here. Lisa Paddock.
Here.
Loretta Springer. Kim Hahn. Kelly Mitchell.
Good morning.
Thanks, Kyle. You guys know we start every meeting with our mantra, all people are empowered to live, love, work, learn, play, and pursue their dreams. Okay, we have a really full agenda today, mainly with Holly. And so we're going to share some information, the level of care assessment, the LCAR, the July 1st waiver amendments, some extraordinary care feedback that we've received that Holly's going to share. We'll take a quick break. And the winter 2025 amendments, a waiver reset update, and then we'll have a little bit of time for parking lot. So if you have any questions or anything that don't get addressed, we can do that then. I'm going to skip that because we're going to do that at the break. Okay, I'm going to turn it over to Holly.
Hey, Jessica,
Yeah.
I would, because I'm loud, I would remind everyone likely to use the mics today. Acoustics in here aren't the best, and to speak up when possible.
Yep.
All right. Is that too loud? No? Okay. All right. Thanks, Jess. So the agenda, I'm not going to go over that again. We'll just move to the next slide, please. Right. So as you all know, we are July 1st launching the phase 2 of the level of care assessment representative. This is a statewide vendor, Maximus, who will be doing nursing facility level of care assessments. They currently do that as part of our pre-admission screening resident review program, or our PASS-R program, if you need another acronym in your life. Beginning July 1st, they will do the nursing facility level of care assessments for individuals seeking those home and community-based service waivers that require nursing facility level of care. There's a variety of reasons that we have moved to a statewide vendor. It will streamline the process, number one. Number two, the timelines for the level of care assessments are 11 days from the date of the level of care request to the date of determination. And it, again, being statewide, we think we will realize, or we know we will realize, some efficiencies there, as well as some added consistency, so that no matter where you live in the state, that statewide vendor will be able to address your assessment in a timely manner. So next slide, please. So as we are looking at the level of care assessment representative, which, if I didn't say this, it's like 11 days from now. Not that I'm counting, but it's very soon. Today, for that nursing facility level of care assessment, we use the Interi home care tool. That is a tool that was designed for adults. Beginning July 1st, as you all know, from previous conversations and communications, we will be rolling out 2 additional inter-eye tools to address or assess the pediatric population. These are also from that inter-eye suite of tools, so they are similar in how they're structured. We have the inter-eye pediatric home care tool that we will start July 1st. And again, Maximus will be using this to assess nursing facility level of care for youth age 4 through 17. And then we have the early years inter-eye tool that will assess newborn through age 3. So as we move to July 1st, individuals will be assessed for nursing facility level of care by our statewide vendor, and they will be assessed using the tool for their age. The other thing I do want to note is on July 1st, Maximus will not immediately reassess everyone for level of care. That will be done for individuals already receiving services, just like today. They will be reassessed as their annual date approaches. Maximus will reach out generally about 90 days before their annual reassessment is due to schedule that reassessment. We have provided training to case managers or care managers on those waivers so that they can help members or individuals in those waivers remember that someone else is going to be reaching out about their level of care reassessment and encouraging those individuals to respond to the contacts from Maximus. I do want to note that with Maximus and the level of care assessment representative launch on July 1st, it is not the level of care assessment process and determination process is not varying from what we have in administrative code is what meets level of care. That has not changed. It is simply who is doing the assessment. We may, in full transparency, see some individuals, specifically with the new pediatric tools that may not meet level of care, utilizing these tools. But again, the nursing facility level of care criteria has not changed. You may recall that on the health and wellness waiver, if an individual is on that waiver and no longer meets nursing facility level of care, we have already added reserve capacity on the family support waiver so that if that individual meets the level of care for the family support waiver, there would be a slot available for them under that reserve capacity so that they can maintain services. I would also note that any level of care denial, just as it is today, will be reviewed by state staff before that final determination is made. All right. So again, the impacted waivers by the level of care assessment representative is includes the health and wellness waiver, the traumatic brain injury waiver, and the Indiana Pathways for Aging waiver. The traumatic brain injury, as a reminder, people may be eligible for the traumatic brain injury waiver if they meet nursing facility level of care or if they meet ICFID level of care. So we do have individuals accessing the TBI waiver that have ICFID level of care, which is not part of the level of care assessment representative work.
If they meet ICFID level of care, will there be some kind of assessment like an algo or anything to determine any kind of need of care?
Any kind of what?
Like the algo, like we do on that side?
So it's not an algo per se. BEADS will continue to use the level of care tool we use today for those individuals. So if, as an example, that's a great question. If an individual is connected with Maximus for a nursing facility level of care assessment and is interested in the traumatic brain injury waiver, Maximus will do that assessment first, which is actually how it works today. The AAA or the ADRC, Aging and Disability Resource Center, I have to stop talking in acronyms, apologies, does that nursing facility level of care assessment. So Maximus will do that assessment. If that person does not meet nursing facility level of care, and there is a presence of an intellectual or developmental disability or related condition, they will be referred to BEADS, and BEADS will do an ICFID level of care assessment.
I have a question.
Yes.
So when they sign up or when they call the Maximus, where do they sign up for, health and wellness?
So when they contact, that's a great question, Sean, and we'll kind of get to that, but just real quickly to answer your question. When someone is connected with the level of care with Maximus, right, for a level of care, we think many times they'll be asking for the health and wellness waiver or one of the other waivers, right? That level of care assessment will be completed. And then if they're 60 and over, level of care assessment representative or Maximus will talk with them and do what we call intake counseling. So they'll talk with them about the pathways for aging waiver. If that person is not 60, they'll be connected back with the Aging and Disability Resource Center or the Area Agency on Aging for what's called options counseling, which will talk with them about the health and wellness waiver. We'll talk with them about the wait list for the health and wellness waiver, the reserve capacities for the health and wellness waiver, and also non-HCBS services that they may be eligible for. Does that answer your question?
No, he just saw me move the microphone. So I know we're going to get into this. So I don't want to go deep. So you can just say, Kim, wait. But what if the health and wellness waiver is not the appropriate waiver, right? If they should be on the family support waiver, will Maximus then refer them to
Sure.
the BEADS office?
Yes.
Okay.
Absolutely. And the ADRC would also
Okay.
refer them to the BEADS office. I think that's a great point, Kim. BEADS has worked with Maximus and that's our role for years. So there is already, our districts already have knowledge and relationships with Maximus staff that will be doing these assessments. Not necessarily with the people that do the assessments, but with the management and supervision of in Maximus.
Okay. Can I ask a question relevant to what you did talk about? So the alert that you sent that said that some people in that pediatric would probably may not meet level of care. Can you just unpack that a little bit? Is that just because the assessment tool is
Yes.
more rigorous?
It's not the assessment tool is more rigorous, it's that the assessment tool is designed for, right? So over the years, we've been using that pediatric or the NRI home care tool that was designed for adults.
Mhm.
So there is that possibility that as we use those more appropriate tools that are actually designed for youth, that some of them will not meet.
Okay.
Yeah.
And then when you say this, I'm sorry, Kate.
No, it's okay. I think we're gonna be tag teaming some questions here.
So then so if there's a denial, then and it goes to the state, how long does the state have to review that denial and either confirm the denial or ask them to
We
rethink?
try to do that within a week
Okay.
or two. I do want to just make note that those denials today, again, are reviewed by state staff and will continue to be reviewed by state staff. But if the person is already on a waiver, which I think is what we're talking about, right? Their services won't be impacted until that denial goes through. And then there's that appeal process if they choose to pursue that. So just want to clarify that if it takes us 2 weeks to get to that,
Yeah.
there's no harm, no foul to the individual.
Okay. Thank you.
Mhm.
I'm done.
No, thank you. So I have a couple of questions. One about the notifications that are sent to eligible recipients of services or folks who are applying for services. The letters, is there the opportunity for a consumer work group to review the letters from Maximus to make sure that they are clear and transparent on what the changes are? Those letters that come out to folks tend to be very heavy on the jargon, and we want to make sure that they are accessible to our population in the language that, not just the spoken language, but also in just the words themselves, that it's very clear what's happening.
And you're talking about the eligibility,
Yes,
the eligibility or.
I'm assuming that Maximus is the one that
Maximus,
distributed
yeah, they
the
will
letter.
issue the nursing facility level of care determination letters or outcome letters.
Mhm.
They will issue those. Now, those are already drafted and in
Right.
place. There's, pretty specific requirements about what we have to include in.
Yes.
Because of due process. So,
I'm just asking if there's a possibility to make sure that people who receive the services are understanding the language that you're already using in the letter, so that there is clarity on why they may not be eligible.
I think that's a good point. I will say case managers, right?
Mhm.
They do have some responsibility there in helping people understand that process. Now we have, and we'll talk some more about this, but we've talked about it before that Maximus will do those annual reassessments. So the case managers will not have to do that moving forward for the health and wellness and TBI waivers. So they're actually going to have a little more time to spend with the individuals and in supporting them and helping ensure they understand the processes related to the waiver. I'm not saying they don't do that now, but they're going to have a little more time to do that, and they will be available to help individuals understand those letters as they come out.
But if case managers aren't doing the assessment, how will they be able to facilitate a conversation about understanding why they were denied? If they'll have a report, I would assume that Maximus gives or just their determination, but just wondering like what kind of detail case managers will be given to help, like the case point to help individuals actually understand.
Sure, they'll have access to that assessment and that decision. So the individual and their legal rep will receive the determination or outcome letters, right? But case managers will be able to see in the system the decision and be able to work with them, and they'll have access to the assessment. Okay, good questions.
I have one more, I'm so sorry. With the transition to the new tool for pediatrics, is there a possibility or any discussion about having some kind of graphic or plain language information that describes the differences for folks so that they understand this is the assessment for adults, and when we're looking at pediatrics, these are the things we're looking at for pediatric assessment? I'm just thinking from the population perspective of needing to understand those differences and how they changed and why those things are different now.
Yeah, so I think the reason those things are different now is kind of how we've talked about those tools are designed, and these are not, I want to be clear, these are not like homegrown tools.
Right.
Many states use these. These are validated and norm tools, standardized tools, so that when people are assessed, they are assessed in a consistent manner based on the age. I'm sorry, you need to say something.
Well,
Go ahead.
I was just gonna add, I think perhaps we could give some examples broadly. Because as you stated earlier, the tool itself is not designed to preclude anyone from being eligible. It is to be age appropriate, so I think we could give examples of if we were assessing an individual's independence in eating. If we are looking at a 1-year-old, we're not going to, as it is now, an adult tool, can they make a sandwich by themselves, I'm being a little bit.
Can they bathe themselves?
Can they bathe themselves? So it's to be developmentally appropriate, where that is, the tool now is built to
Yeah.
assess an adult. Particularly a senior.
Yeah.
Adult And so this is just more appropriate. So I think we could give some of those broader examples just to explain, it's not that, to your point, the requirements for nursing facility level of care eligibility have not changed with the use of the tool or the differentiation of the tool. And the individuals completing those assessments are being trained on the tools to understand those distinctions.
Yeah.
Would that be helpful? I mean, just be a little more broad that.
I don't think so.
Oh, okay.
I don't know if a comparison between the two, I know people
Yeah.
would love to see them. Right? So I don't know if you can make the tool available so that people could look at them, because that's the one thing that my team has said, that if they have just a way to just look at the tool.
Yeah.
Part of me thinks just, and I'm just speaking to myself, if I hadn't seen anything and I'm trying to, well, this has it, this doesn't, that's helpful to a certain extent, but I would rather read it, see it myself, and then get an understanding of it myself. I don't think either way is wrong.
No, I do,
but-
and I think the clarity between an adult level care assessment and something for pediatrics makes so much sense. And it makes sense that these are tools that have been vetted, they're high fidelity models. I think when we're talking about how we communicate this to the population and community members, that transparency piece and being very specific and saying, we really want to look at level of care for the pediatric community, the pediatric population, because we know a 1-year-old cannot make their own sandwich, right? Like that makes sense, but it's that transparency piece for families that I think is gonna be important, so they don't, there's less confusion, I guess.
I think I would liken it to, if I might, to first steps when you
Yeah.
look at eligibility. And we know that's at birth to 3, but when you're assessing a child, are they developmentally appropriate? You look at, birth to, 6 months or 12 months, or, what would be typical expectation developmentally appropriate in the range. So it's the same approach, that it's just a developmentally appropriate assessment tool. So similar, to how we approach eligibility for first steps.
And I will just add, I don't think we're not trying to be untransparent.
No.
I do think those tools are proprietary tools, and I think we're going to have difficulty sharing the entirety of the tool with people who are asking for it without there being a pretty notable financial issue. That is why I think we're focusing on giving some specific examples of how it would be applicable, if that makes sense. So I don't want people
No.
to think that we're, over here kind of sort of gatekeeping the tool, but I do think if we can put together some more specific examples, I mean, because this will, as you all know, later this year also be applied to the other waivers that we administer. So I think we can work on putting some examples together, just more to, I think, to your point, help describe maybe the developmental sensitivity of
Yes.
the tool.
That's what I'm trying to get to. It's just the really descriptive pieces between it. I don't want to see the whole tool, and nobody has time for that, but but I think from a family perspective, it would be really helpful to just understand those differences, and folks, a lot of families are just really busy in raising their kids. So understanding those pieces in a short form is going to be really helpful.
Well, I think the other thing is the fact that as we give education about the tools, it helps prepare for the future.
Yeah.
So if first steps goes by standard deviation, school goes by standard deviation in some of the things, and explaining, and I prefer also giving that example, right? Because that's the reason that we're no longer using an adult tool. But as we can help families be assured what standard deviation means, what would that look like, right? And we're looking for this at this age, and your child is or is not able to do it, especially because as we now look at this, some kids won't have that level, reach to that level. I just think that's where the transparency piece of, here's why we had to change it. I think most people agree with that, because you get that, hey, no, we can't make a sandwich, right? But when it comes down to developmentally, because many of those same families are going to have been concerned, been at the pediatricians operating, you know, working through first steps. So any of that educational continuation that can help them understand where their child is and what services they're interested in, I think would be really helpful. And letting them know that this is a normed tool, right? You can't see it because it's proprietary, but it goes, other states are using it, and this is what it's based on.
Thank you. Oh, yeah, let's.
I wanna make sure that, and I'm sure this is probably the case, but I wanna make sure that families who may not qualify with maybe their first assessment from Maximus has a chance to reapply every however often, because, at 6 months, an infant may seem developmentally in the right spot in that moment, but sometimes, like with developmental delay and developmental disabilities, that the milestones, like they start to not meet them at a certain age or fall back at a certain age. That happens a lot with autism, where like a 1-year-old will say a couple words, and by 2 they're non-speaking. And I just want to make sure that as developmental milestones may or may not be met, there's flexibility for reapplying and
Yeah, I think that's a great point, Lexi, because you're absolutely right. Children develop differently or on a much different scale than adults, right? So that's a very good point. So thank you. Thank you.
Hey, Holly, I'm
Yeah.
gonna move you.
Yeah, I was gonna say, I probably need to, I wrote the times down.
But I factored that in, so we're still.
Okay, all right, okay, very good. So, again, Maximus is July 1st, we'll be doing those initials and the annual reassessments, issuing those determinations along with, of course, appeal rights. And then intake counseling for the 60 over population. I do want to note, while not particularly relevant for this group, the Indiana Pathways for Aging. So individuals receiving services through the Indiana Pathways for Aging, or individuals who are 60 and over in pathways or Medicaid eligible, their MCE, their managed care entity, will do an assessment for nursing facility level of care. It's called the CHAT, Comprehensive Health Assessment Tool, because everyone needs another acronym in their lives. But that is then submitted or will be submitted to Maximus for review and determination recommendation. So it does look a little bit differently or different for pathways on those annuals, and even the initials if somebody's already has a managed care entity. So, all right, next slide. This, I believe I've shared before, but it just reiterates that there is still roles for the area agencies on aging and the Aging and Disability Resource Center. They will, of course, make referrals to Maximus. We know July 1st, despite communications and outreach, that some individuals are going to go to the ADRC in their community and say, I'm interested in a waiver. The ADRCs will connect them with Maximus. The ADRCs will continue to support Medicaid application assistance where needed. They are continuing waiver case management. They will be providing waiting list support for the health and wellness and pathways waivers. Options counseling, as I mentioned, for the under 60 population, they'll continue their work with no wrong door.
Can I ask a quick question, Holly? You said that if someone contacts like a AAA for health and wellness, they'll connect them, but you almost made it sound like that's maybe not the point of entry anymore. Is that still?
No, it can still be a point of entry because a lot of folks that are looking, as you all know, I'm preaching to the choir here, a lot of individuals that are looking for support or services, they don't know what that looks like, right? They just know they need some help, right? So we know a lot of people will connect with their local ADRC who will have that conversation with them. And if there's an interest or potential the person might be eligible for a waiver, they'll connect them with the level of care with Maximus. If their indication is that the person is not interested in that, for whatever reason, they may talk with them about non-waiver services or just other community supports that they need connected with. They get a lot of calls, just like our beads offices, about, I need help with housing, for example, and they would just connect them as they do today. Okay. Thank you.
I have a question. So where do people sign up for the path?
When they're interested in the pathways for aging waiver. Sean, is that what you're asking? Is that entry? I'm sorry.
Yeah.
Okay, that's fine. They can contact Maximus or they can talk to their MCE. If they are 60 and over Medicaid eligible, they can just talk to their managed care entity and begin that process. But if they call Maximus, they'll work through that with the MCE so that those individuals can be assessed.
May I use this as an opportunity to clarify, and I think you were doing that when you said, do you mean the pathways for aging waiver? And I know in general population, and well, on us all, this can be confusing, but pathways itself is the managed care program that brings together Medicaid and Medicare and coordinates that healthcare coverage. So an individual 60 plus accesses pathways for their, you know, their healthcare coverage, that what we know is traditional healthcare coverage. And so it's coordination of those benefits, Medicaid and Medicare. So that's pathways. Individuals seeking home and community-based services through waiver that are 60 plus, that is the pathways for aging waiver. That then is where Holly referred to Maximus as putting that level of care assessment or, you know, connecting through your managed care entity. And I think you have a slide, but when we talked about, can they still access waiver by going to the AAA or the ADRC? Yes. They can also go directly to Maximus, and we'll talk about that later, a website, a phone call. There are multiple ways for individuals to be supported in connecting directly.
Correct.
When an individual is onboarded, who will be providing choice of case management? Will it be the ADRC or will it be leads? Because that would be kind of hairy.
Just to clarify, when you say onboarded, because I don't know that everyone knows what that means. You and I know what that means. Okay, so I think what you're referring to is when an individual has a waiver, new to waiver, and for the health and wellness, traumatic brain injury waivers, who's going to offer choice of case management?
Correct.
That will be the Area Agency on Aging. And that is being routine. If you've joined any of our provider and case management webinars, you know we are continuing to reiterate that that is a requirement, that individuals must be given on the waivers, they must be given choice of who's going to provide their services as well as including case management. So, and if there's experiences where that's not happening, we ask that we get specific so that we can address that. All right, I'm gonna move on because otherwise, well, Jess is too far away. She can't post it.
Just give you that look.
That look, right. So I have included here some examples. I don't know that you all want me to go through these specifically, but what I'm trying to demonstrate here is how things exist today and how they will exist July 1st from the individual's perspective. This one is if someone's at home seeking nursing facility admission, and this is an under 60, you will notice, 56-year-old living in own home, wants to pursue facility admission. Today, the Aging and Disability Resource Center completes an assessment. Maximus reviews it and issues the nursing facility level of care outcome. If approved, the individual may transition to a nursing home. Next slide. As of July, you will see it's very, very similar, except Maximus will do the assessment of the individual and then issue the outcome. And then things move forward accordingly. Next slide, please. So
Is that the right one?
That's it, health and wellness waiver today, yes. So same individual, 56 years old, living in her own home, wants to pursue the health and wellness waiver. Today, she's connected with the ADRC, or the Aging and Disability Resource Center. They conduct that nursing facility level of care assessment, make a determination recommendation, and issue that decision on the nursing facility level of care. And then if approved, the individual will either transition to the waiver or to the wait list, be placed on the wait list. If denied, that ADRC will work with them on other resources. The other important thing that's really tiny there, or at least it looks tiny to me, the ADRC can, again, in those situations, if the person is not Medicaid eligible, can support them through that Medicaid application process. Next slide. This same 56-year-old, same situation, living in her home, wants to pursue the health and wellness waiver. She'll be connected with Maximus through a variety of ways and through a variety of entities. She'll be connected with Maximus. Maximus will complete that assessment, make a determination recommendation, issue the outcome, and then it's, again, if approved, may transition to the waiver or to the wait list. And then if denied, that individual will be reconnected with the Aging and Disability Resource Center, potentially to look at non-waiver services or other community supports. I did include examples here, next slide please, on pathways. I don't know that I'll go through this, but I did just want to note, because it isn't very relative to or relevant to this group, but I do want to note here, and you'll see in here what Kelly was talking about earlier and what I was talking about with, if they're over 60 and not a Pathways member, that means they're not Medicaid eligible, right? So it can be a little confusing, but just wanted to call that out on these slides. And then, of course, if they want to pursue the Pathways waiver today, it's through the ADRC. Next slide, please. And then July, it will be their Maximus will actually finalize the assessment, the MCE. Well, if they don't have Medicaid, I'm sorry, if they don't have Medicaid or they're not a Pathways member, Maximus will do the assessment and then issue the outcome. If the person has Medicaid and is a Pathways member, the MCE will do that and submit that to Maximus. So again, not incredibly relevant to this group, but wanted you to have that information. Next slide. This is some of the ways, probably the most common ways that people, no, not most common, people can be connected with Maximus beginning July. They can call. I can call for my mom even and say, hey, I'd like my mom to have an assessment for nursing facility or for the health and wellness. Well, she would be Pathways, the Pathways for Aging waiver. There is a website that Maximus has in lcar.com that has a contact form. My mom or I could go on that website and fill out that contact form, and then no will respond. If they reach out to an ADRC, let's say I call Lifespan Resources down where we live, they can actually do either of those things. They can do a 3-way call. They can do the contact form. If I say, oh no, I know where that is, I'll take care of it, that's okay too. Or because the AAAs have access to Assessment Pro, they can actually go into that system and do a level of care request. And then there's also an email, and I neglected to put that on here, but there's a lot of different ways that people can be connected with Maximus, and a lot of different entities that can do that connecting for them, including the B's office, the ADRCs, providers, any of those can assist that. Yes,
Quick question.
sure.
What is the anticipated timeline between when somebody gets a referral to Maximus and when the assessment will be complete? Is there like a
11
benchmark?
days. 11 days. And I do want to note too, again, Maximus does the pass R work as well. That timeline is a couple days shorter. It's 9 days for pass R, and that's not changing. That's federal. That's not changing. But 11 days is a pretty quick turnaround. So we're happy to with that timeline. The other thing I want to mention before we go here, which is okay because it's not on a slide, so just didn't know. We also on July 1st are, and we've talked about this, but just want to remind everyone, waiver consolidation. So case managers today work in the for the health and wellness and traumatic brain injury waivers work in the CAM system. On July 1st, they will begin working in the BEADS portal for the health and wellness and traumatic brain injury waivers. We did a training yesterday with them and are doing another one today. So pretty excited about that. CAMS is not very intuitive. So we're excited to get case managers on board using the BEADS portal. And we continue not just for state staff, but for our stakeholders as well as that path on system consolidation. So that we can be more efficient and not have people working in 2-3 different systems. So. Okay, next topic. I'm a little bit over, but we'll be all right. We'll be all right. I can talk fast. So as you all may recall, we submitted waiver amendments on Valentine's Day, actually, to our partners at CMS for the health and wellness, traumatic brain injury, and the pathways for aging waivers. That's B and C. And next slide, please. Wanted to just go over briefly what was in those changes. They did get approved. How did I not mention that first thing, right? Those have been approved. And the biggest piece of those amendments was the launch of the level of care assessment representative and that statewide vendor. Previously, our waivers gave that authority, if you will, to the AAAs, the area agencies on aging. So those amendments were necessary to be able to move forward with the level of care assessment representative. So in the health and wellness waiver, of course, was the LCAR contract. We've already talked about some of the other things, the revision of the unduplicated number of participant counts, the addition of the reserve capacity for individuals residing in assisted living who spend down their resources and become newly Medicaid eligible. So we have approval for that now. And that's in addition to the money follows the person reserve capacity so that when individuals exhaust their 365 days of eligibility for money follows the person, there will be a health and wellness slot available for them should they be under 60 and meet nursing facility level of care. And then we modified the language around the assessment tools as well. And then technical changes. Next slide. The traumatic brain injury waiver was also very similar. It does not have the reserve capacity for the assisted living, but everything else is as it was with the health and wellness waiver, with the biggest piece being that launch of the care assessment representative. On the pathways, the C waiver, again, the launch of the level of care assessment representative, our work around the unduplicated count, the assisted living reserve capacity was also added to the Indiana Pathways for Aging waiver, as well as it was to the health and wellness. And then also in the Pathways for Aging waiver, we replaced references to the AAAs conducting the options counseling with Maximus or the level of care assessment representative, completing that for the 60 and over population. We also, in March, that I don't remember the date like I remember Valentine's Day, we submitted renewals for the family support waiver and the CIH waiver and the associated B4. The next slide, please. The family support waiver, again, we had some updated references to the 1915 B4, which is the case management vehicle. Where we were able to do, or are able to do that selective contracting. So we updated some references to that. The unduplicated count that we've talked about, and the cost neutrality, and then just some language cleanup. So not a lot of changes on that renewal. The same,
Yes, real quick, you haven't heard from CMS if those.
those were approved.
Oh.
I'm sorry, they were approved at the same time as the amendments, so. And there should be an announcement going out about that. We've been working on getting that posted. Yes, for July 1. Well, the family support waiver and the CIH waiver, actually July 16th. But July, yes. So we were very happy to get those approvals back from our developers. On the family support waiver, we did do a little bit more in that we revised our wait list description just to further clarify. We did revise some reserve waiver capacity counts that we talked about before, where we had just seen more people utilizing some of the reserve capacity, and we needed to adjust that. And then some technical changes. The language, next slide. Now, the 1915 B4 case management renewal, you all probably recall when we posted that, we're also required by CMS when in the situation of a B4, a 1915 B4, we are required, or states are required to complete or have completed an independent assessment of that B4. And that is required to be posted with that amendment or that renewal, which it was. You may recall that was, I hope you recall, that assessment was positive. But we also made some changes, just updating the individual served, because we are serving more people now than we were when we initiated that before. Same with the caseload values. We did some updating on the monitoring methods we're using to better capture what we're actually doing. And then some other changes just to make sure it's current. I do want to note, the assessment, as I said, was positive. I hope you've read it or had a chance to take a look at it. We do intend to expand that B4 in the future for the other waivers that we administer. We have seen some good things come from the B4, so we will be looking at doing that in the future for the health and wellness and traumatic brain injury waivers. All right, next slide, please. Now stepping out of the waiver amendment space for a minute, just to talk briefly about the home and community support professionals. Well, while I check my time. Okay. Oh, good. I'm already ahead of schedule now. So there was a recent announcement that I'm sure you all saw about the home and community support professionals, or what we traditionally have called DSPs, direct support professionals, but wanted to make sure the language was descriptive. So
It actually applies to anyone applying direct services regardless of their type.
oh, okay. Thank you
I've
for
been trying to
clarifying.
clarify that, because I know sometimes folks that aren't
Mhm.
DSPs also.
Also,
direct
yep.
services.
Good point. This training is required for applicable services under the family support and community integration facilitation waivers. And that is effective July 1. The HCSP must successfully complete the modules within the two curricula, and there's a foundational and a fundamental curricula. So they must complete all those modules to receive certification. Now, to clarify, and I think this has gone out or will be going out soon, the certification for an HCSP must be obtained by January 1st of 26. So I think we had originally been looking at July for new, but we have heard from our partners that they needed a little more time, so we're going with the January 1st of 26.
Well, can I,
Yeah,
a bit
you
of
can.
clarification,
Yeah.
that's good, please jump in. When we referred to the July 1, there was guidance that we're hiring someone new. After July 1, they should use this platform versus what each provider had previously utilized. So what we have put forward is understanding people may need some time or entities may need some time to adjust. We're gonna push that and say August 1. If a provider can choose to use that platform July 1, if they're ready, because it's online and accessible. There's nothing for a provider to, you have to download or incorporate in their system as long as they have the credentials and access. But we also know there will be hitches. But the January 1 is every individual, and this is following the legislative mandate. Every individual that would be providing direct services under that CIH or FSW must be credentialed, have the HCSP credential and on the registry in order to provide reimbursable services under those waivers. So.
Can I just make sure I understood on the August 1? So you just said, on August 1, new hires should be trained on this registry. Like be given.
That what I'm saying, is August 1 going forward, if you hire someone to use this system.
Got it.
It
Thank
should
you.
be ready for providers to access July 1 when we roll it out, but we also understand. Again, we aren't going to be aggressively looking, say, oh, Susie didn't get trained and we're shutting you down. Because these are things that we will monitor through an audit process, as you well know. But we didn't want to cause any burn, if you will, in the provider community. And unnecessary concern and angst. So that was just to give a little bit of a runway. We'll continue to monitor this, as we've said all along. If there are issues on our end systemically, obviously we will adjust accordingly.
So this is more about people like who we traditionally describe as DSPs, or maybe a house manager or something. Yeah,
Okay, I
right.
to be clear, or I don't want any confusion, it could be residential manager
Right.
providing direct services. They would still need the training in order to provide it, but that's the case now.
But nurses, music therapists, VCs, yeah, okay.
This is.
Yeah.
You know, those things that res has, participant attending care services, respite, the traditional direct support professional would provide. I think the other thing that I would use is, because we've gotten a lot of questions. The requirements for training have not changed, so we are still working within our administrative code, which is 460 IAC 6, which has always had a very prescriptive requirement for what topics must be covered, that competency must be demonstrated, and that the training must occur before anyone provides a service to an individual, and that they have to retrain annually. Now, we are making some modifications in administrative code. To actually, we hope, provide more quality. There'll be that initial training. And one-time annual training follow-up, with few courses. And then we're gonna move that to every 2 years. And allow some augmentation of skill sets rather than repeating the same things. I know I did this for 30 years. I didn't need to have that same training 21 years in a row. So we really want to look at enhancing quality, providing consistency, because how it exists now is every provider develops their own training program and implements in a certain way. It is very difficult for us to ensure consistency and quality of that training, not questioning anybody's ethics and compliance, but I know in our audits, we are finding some wide variations in the quality and the consistency of training. The biggest plus to this, I believe, is that this credential is portable. Our current system, if Acme Inc. hires me today as a drug support professional, they train me using their program and their curriculum. And if 6 months later, I decide that I want to go work for Holly's home care, she has to train me in her program on the same things that I just trained on 6 months ago with Acme Inc. before I can deliver 1 unit of billable service to the individuals that she supports through her agency. Now, I have this credential, I can go to work. Once I get my individual specific training, I will never not say that. It's still required when we work with an individual, it's specific and we are trained on the needs and wants, the goals of that individual prior to beginning. But this now becomes portable, and that public registry will say Kelly Mitchell got her HCSP credential on said date, and it will show when I retrain and any additional classes that I might take. So that is a benefit not only to providers, but to individuals and families to be able to see that. So I'm excited. We know, as with anything new, we'll have to iron out wrinkles, so please understand. We will listen and we will approach it accordingly.
How many are you, how many home and community support professionals are you anticipating?
You know, we are taking a bit of a stab because, as you well know right now, we don't really have record. The providers do, obviously, their payroll records, their higher personnel records. We don't have a listing of individuals. We're estimating around 20,000 direct support professionals, and 20 to 30. And so I think that's the other thing. If I look at it from a provider perspective and a planning perspective, I think this gives us a handle on who do we have, what is our workforce, and how might we plan accordingly, service structures and attraction and recruitment and all of those factors. So I think this is going to give us some really good insights that we now do not have.
When will the registry be public facing? Is that January 1 of 26 as well?
And Jessica, you may want to speak to this because she's really, I can't give her enough credit. She's like really leading this so well. The target is that it's up and running by July 1 or January 1, excuse me. I believe it will launch within that. The last that I sat in with the vendor Syra, that they are developing that alongside the curriculum and the platform, shoring up the platform. So I would anticipate it to go live near the launch of the platform itself.
Okay.
But we obviously want to ensure that everything's working appropriately before we would make it public facing.
Just a couple questions, excuse me. I see the two family support waiver, community and rehabilitation waiver. Does the training, is it being used for any other waivers?
Not at the present time. The ultimate goal is that this would apply as foundational across all waivers. And initial conversations and I hope to connect and actually we are connecting with Department of Health.
Yeah.
I think as we think about home health, can we use all of this as foundational and get some consistency across not just divisions and waivers, but agencies? But right now, you all know we're working focused on these two waivers. We're also working within some budgetary, constraints and making sure that we can roll this out effectively and efficiently.
Then my follow-up with that is, can you just speak to the focus on specifically intellectual and developmental disabilities? in the content and the delivery. Is the training focused on this population, or is it more generic, can be applied to anybody receiving any type of service?
I think there's two problems. Yes, it could be applied to anyone, and there are specific components that are focused on those with intellectual and developmental disabilities.
Well, and Kelly, it's gonna align with 460.
Yes.
So the training requirements that people are currently trained on.
And right now it's in a pilot testing phase. So we actually have providers and direct service workers who are using the system, giving feedback on not just the curriculum, but the ease and navigation, so working out those pieces.
Lexi, were you raising your hand?
I was. So I like the idea of trying to bring it across, all aspects of care. My DSP with my, PAC provider is currently going through her orientation at my home health company. She went through all the training with my PA company. And she said she felt like, the training that she got to get hired as a PA home health aide, some of it she felt like they should add to the trainings that she received as a DSP, because that's what she did first. So I'm hoping that as this expands over not just the waivers, but PA and other things, like I'd also like to see the registry do. I think it'll just make things so much more universal and smooth flowing for those of us who have multiple disabilities.
That's good feedback.
Yeah, I think, let's say, keep that stuff in mind, because right now we're focused on the required. This is a really big initiative we're focused on what's required right now, just because we're following a statute and we have, deadlines, which is fine. So, but yes, please keep that stuff in mind. There's gonna be, the goal is, and again, Kelly, we are under some budgetary constraints as well. But the goal would be that there would even a goal to have like optional type trainings that, someone could go in and they're not necessarily required, but a provider could choose an optional training to say, hey, I think it'd be really great if Heather. So again, that's a goal, and I think hopefully we'll get there. But again, just focus right now on that, requirements, just to get those rolling in live by July 1st. So. And always welcome feedback. I mean, I think there will be there's a helpline. So as DSPs, as the home and community support professionals are taking it, please, we want feedback. I'm not saying something's going to change a week after it goes live if it's a suggestion, but we always want that feedback from people, obviously through the pilot, but as we're taking it, because we can always take those into consideration. It is being built so that it is not hard to edit or navigate. The goal, right, is that it wouldn't be hard if we needed to make some changes. So, yeah, the updates and exactly. And obviously when things change, it'll be updated, if there was some change in as Derek said, this is broad. These are somewhat broad topics, right? So there's person-centered training, right? But if there's something that changes, or there's a industry-wide, edit, whatever you want to call it, right? Something that, obviously those trainings will be edited to fit within those standards across the population. So
Are the modules there? It sounds like they're recorded modules. Are they taught by other professionals in the field? So it's more of that peer-to-peer model. And is there an opportunity for peers, direct support professionals to connect with other? I know they can within their provider agency, but creating that network of peers in the field might bring some solidarity and kind of like a community of practice with some of this.
They're not really recorded. They're interactive, learning, it's a learning management system.
there's examples. I wouldn't say
There are some, video. You know what? I like the suggestion, or, the community practice and connecting, direct service workforce. Perhaps we could do that through, some of the direct support professional groups.
I'm mostly drawing on that, from the mental health model, the
Yeah.
certified peer support specialists, they do training peer to peer, and that works really, really well. So just thinking in terms of what can we have some parity with that system so that when there's crossover, when we are working with folks who are duly diagnosed, even that crossover of training of peers is really helpful, so.
No, that was it. It is exciting. It's very.
And we'll have there'll be an FAQ that's going out really soon. We're finalizing that. I think will address a lot of questions that we've gotten. Extending that deadline has calmed people quite a bit, which is good. That was the goal. I think we heard you. So we heard you. So I appreciate, the feedback. Again, we do take that seriously, and want to hear from folks about this and things. So yeah, so keep it coming.
All right. The only thing I would highlight on this slide is just a reminder that the HCSP must work for an enrolled provider and that self-directed services will require the HCSP. I'll get that acronym down. Employment.
You have the home and community base. It's hard, I know.
Yes, through the fiscal intermediary. So just wanted to clarify those points real quickly.
Can you repeat that about the self-directed?
Yes, the self-directed services will require that HCSP employment through that fiscal intermediary. And we'll talk a little bit more about self-direction today. All right. So, I'm going to step into some new space here and talk about some proposed items for a set of waiver amendments for implementation in the winter of 2025. Want to start with the extraordinary care. I know we talked some last month, although it seems like it was probably 3 or 6 months ago, but I think it was just about less than a month ago, actually. Wanted to go over the extraordinary care information again and then talk a little bit about some of the feedback we've received. So again, extraordinary care is a characteristic of the individual receiving or participating in services. And CMS requires that we and other states define extraordinary care to ensure that states are not reimbursing for services and supports that legally responsible individuals or LRIs are otherwise obligated as parents or spouses to provide. In Indiana, next slide, please. I just waited till you got up before I said that. Legally responsible individuals in Indiana includes parents of a minor child and spouse. Legally, an LRI does not apply to the parent of an adult waiver participant or other family member, other caregiver, if you will. And just also to reiterate some things that we talked about last time. When states allow LRIs to provide paid support, we have to ensure, CMS requires that we ensure that that LRI providing that paid support is in the best interest of the individual participant. And we are required to make sure, of course, that payments are only made for services rendered. Next slide. So today, in June, LRIs can provide structured family caregiving when the individual requires extraordinary care as defined for that structured family caregiving service. That's on the health and wellness, the TBI, and the pathways for aging waiver. In the provision of structured family caregiving, for that extraordinary care threshold to be met, the individual must require day-to-day care or support activities provided by the LRI that exceed the daily care that an LRI ordinarily would provide or perform in the household on behalf of a person of the same age without a disability or chronic illness. So structured family caregiving, as we all know, is a a per diem service. And we made the decision some time ago last year to allow LRIs when the member meets that extraordinary care definition I just reviewed. We allow LRIs to provide that on those waivers. Our intent is to continue with that as it stands, recognizing that structured family care is different than, for example, attendant care. And the provision of supports in those different models is significant. So. All right, next slide, please. Last month, earlier this month, whenever that was, that we last met and talked about the draft of extraordinary care as defined in the provision of attendant care. So again, a participant would have to meet the definition that you see on the screen and that I'll read in order to be able to have an LRI provide attendant care or participant assistance in care. So the attendant care would be health and wellness, TBI, pathways waivers. The PAC would be the family support waiver. Again, this is still draft. We have obtained some public comment, but there will be more opportunities for public comment when these amendments are posted. So this is what we have as draft. Individual demonstrates care needs that are provided by the parent of a minor child or a spouse that the individual is unable to perform independently to meet his or her intensive nursing care needs under the supervision of an interdisciplinary team. Intensive nursing care includes continuous ventilator care, trach care, TPN, or other comparable nursing services approved by the Family and Social Services Administration. Additionally, the care must exceed the range of activities that a legally responsible individual would normally perform in the household on behalf of a person of the same age without a disability or chronic illness. So
Holly,
yes.
That third component is really the only component for structured family caregiving, but then you're adding two additional components for the same definition of the same thing if they're getting these other services. Is that correct?
Because the services are just different, right? Like the structured family care is it's just qualitatively different than the attendant care hourly service.
Okay, so basically the distinction is that the attendant care is much closer to like nursing.
It's a personal care.
Yeah. Okay.
So I do want to talk a little bit more about this, and I also want people to ask questions, but before we dive into that, I do want to know what is on the slide here, that saying that an individual receiving services through the waiver has extraordinary care needs and an LRI can provide attendant care does not mean that the LRI providing the attendant care can meet those skilled needs while in the provision of the attendant care service, because that does not align with the service definition. So I've got a couple examples here we can kind of walk through, but I think that can be confusing. So just want to clarify that. Next slide.
And for that third bullet.
Yes.
Can you just help me understand that a little? Normally perform in the household on behalf of a person the same age without a disability. That's pretty broad. I'm curious just how broad that is though in practice, or kind of what your thoughts are. I mean, are we talking? Help me get some ideas of what is considered normal. What would be a normal or expected care that a person without a disability?
So
that may be a person with a disability. If you could give me some examples, I think that if I had to guess, the vagueness there and the interpretation is the crux of the entire how this all pans out. And I would imagine that what that word would normally perform isn't. That will be used across this group and consistent. Across everyone here, I think it's what's normal, or how, what are we willing to do and what we're legally required. Anyway, can you just help me understand what your thoughts are? How did, what is that?
I might add, that exists now, an
Yeah.
application for the extraordinary care definition of structured family caregiving. Holly will likely do this much more justice than I would, but I can give what I think is a simple example. A parent would normally prep a meal for a 2-year-old, would assist in feeding at a certain level, right? However that is done, we don't, the 2-year-old just doesn't open the fridge, get the stove, fix the food. There's some level of expectation, so that's what we're talking about.
For a spouse, someone with a spouse. How does that, would the same be true for a spouse, like? Feeding a spouse?
I don't know if it's about feeding a spouse, but if it's typical that 2 people living in a home would prepare a meal and sit down together, right? There's someone in the home that's gonna prep a meal. Possibly, this hasn't been used to prohibit people from being eligible.
But it could. Right?
Well,
I
yeah.
I mean, so because of the differences of the state. I mean, I think that's great. That's great what has been happening. I just do wonder, just that is so big. I'll just say this, so I would imagine that some family members would be very concerned about that. We're very fortunate that.
Can I give you an example? The Bureau of Labor Statistics published this report on what a parent, the number of hours that a parent would typically provide and support. It's actually data. And it'll say a 2-year-old typically so many hours a day. Now, we don't use that. Let me just state that. But I think that's what we're talking about. What would one normally anticipate in, in a typical situation? It's not used to say, well, you're there, you should do it just because you're there.
Well, like I have a 17-year-old child and I provide lots of things for her, but a lot of stuff I don't. But if that child had a specific, perhaps brain injury or something else, and I had to do hand over hand or bathe her or something like that, that seems extraordinary to me. Yeah, but that kind of seems extraordinary to me, regardless of whether it's attendant care or structured family.
Each other in a pretty significant way. Bullet 2 and 3, talks about this intensive nursing service, and the other one talks about just general care. So it's just confusing.
So I do want to just.
There's 2 things, there's the person and their needs.
Yeah, and I appreciate sort of the sentiment on bullet number 3. Bullet number 3 is federal language. It is coming directly from CMS. And that was our effort to align and show alignment with the federal expectation for our FMAP requirements. So it is a more broadly stated framing by the feds to say, we will reimburse you, state, to provide these services. However, if we deem any of these activities to be within the range of what a legally responsible individual would normally do, you will not get that FMAP, or it will be recalled.
Into that, I guess that's my question. Bullet point 2 and 3 don't have.
Bullet point 2.
I don't have to bathe my 14-year-old, but
Bullet point
it's also not
about
done yet.
individual need and defining it, and I do want to, I am gonna be real, we just stated. The extraordinary care definition as it exists for structured family caregiving remains.
So
that is an option for an LRI to provide the care. This is being considered because it has been elevated to us that there are a very small, tiny percentage of individuals that have such complex healthcare needs that attendant care is the preferred or better option, and I think Polly's gonna walk through that. So what I want everyone to keep in mind, we are not eliminating the ability of LRIs to provide support through structured family care to the individual, and we are not revising that extraordinary care definition. That pathway remains as it currently exists, and no one was eliminated by using that third bullet,
Broader definition.
to provide that care through structured family caregiving. So I know there's a lot of interest in this, but this is something that, based on feedback, this is a very narrow group of individuals, and I will be very clear about that. This is not meant to apply to a large, broad group of individuals. This is folks with extremely complex healthcare needs.
That makes sense. Thank you.
Let's see the question.
Yeah, so I kind of wanted to go back on like the conversation about like the vagueness of it. If I remember correctly, at the last meeting when we discussed extraordinary care need, we kind of talked about that vagueness kind of actually being more of a benefit to the individual and the LRI providing the care, because if we put like a comprehensive list, it basically wouldn't do it justice for the individual and the family's need and the LRI's needs. So if I remember correctly, it might have been you, Kelly or Holly, that said, you know, that so it being vague is actually beneficial because it doesn't narrow things down to just a strict comprehensive list.
Yeah, Lexi, you're right. We discussed last time I think the vagueness was around bullet to the other comparable nursing services, and you're exactly right. Your memory is spot on. And we did get a lot of public comment about that already. So we'll talk some about what that public comment is, but you're right. When we last met, we did talk about if there is a list or if we are too prescriptive, that will limit further who can access attendant care provided by an LRI.
So to that, I mean, I agree. I appreciate the flexibility that opens up, but just thinking about my own situation and that my child is medically complex, but I would not say that he doesn't have a trach, but he's medically complex. He has I would just consider extraordinary care needs. He's 13, incontinent, lots of things. So when looking at the intensive nursing care needs, you know, it has a few listed and then comparable nursing services approved. Is that something that, like, how does that work in practice, I guess? Like, if I think that my child has complex needs that would meet those requirements, am I going to my case manager and saying, I'm looking at, and then they're taking it to FSSA, you know, to get approval? Like, how does that work in practice for families and individuals?
There will be a process where a family or a team would submit something to the state. We will hold the decision-making authority on if that extraordinary care definition is met, because we are held accountable to CMS. And they are very clear in their guidance that states will be held responsible to ensure that we define extraordinary care and that we maintain or comply with that definition that we've established.
So my question is this, and perhaps I'm looking at this wrong, but to me, the vagueness on that last paragraph might be able to include families or spouse for someone who might not be as medically complex, but is very complex and need for supervision and health and safety. I think that's the concern that I have had and that I have seen from other families, that individual not only cannot do what would be age appropriate, perhaps they're not medically complex, they don't have a trach or on a vent, but they are absolute full support 24/7, which has been the lived life experience of many of my friends and people that, you know, come to me, is they are concerned that the medical focus is perhaps drawing away from some of the individuals who could be quite physically healthy, but totally dependent for health and safety on another individual ensuring constant supervision and monitoring because of the level of support they need and their cognitive level at for daily skills. So that's a concern I've heard.
Yeah, and I appreciate that feedback. We did get a little bit of similar feedback in the public comment. I do want to go back to what Kelly mentioned, though. The reason we are looking at that attendant care service is really to address what has been elevated to us for individuals who have family members with complex medical needs. So.
And that is the focus of this.
Right.
I mean, we're trying to be very clear, that is the bullet 2, that is what we would be looking at as far as the individual and their need or condition.
Can I jump in real quick? I will also say it is one of the things that states are required to do is again, ensure that extraordinary care definition is met. And in order for us to do that, we have to be able to measure it as well. So it's pretty easy to measure continuous vet care, trach care, TPN. So as we think about our responsibility in monitoring, we have to think forward about what that criteria would look like. And again, this is really meant to address those individuals and families that have those complex medical needs that have said the structured family care does not adequately address those needs. Were you going to add something else? Sorry.
Yeah, and just again, trying to put this contextually, I think you all know, we have to work toward a sustainable system. We are working within, we know the fiscal environment, we are working within budgetary constraints, and we have to build, as we spoke last fall, a sustainable model. This is in response to feedback that we received around the structured family care, allowing LRIs to provide care that in certain instances it's not adequate, where we hear because of the health condition, no other individual can come in and compromises the health, those type of things. We know the situation that led us here. We weren't able to adequately monitor this, and we ended up in a pretty difficult fiscal state. We also had instances, quite honestly, where individuals, families were being, there was exploitation in the system. We need to ensure, as Paula indicated, that does not occur. I would also say to everyone, this is an iterative process, and you're going to speak to this. We still are moving toward waiver reset, which includes not just a new array of waivers looking differently, but looking at what types of services should be there. So we would be looking at, is attendant care the most appropriate when we're thinking about family caregiving? Is structured family caregiving? So know that we are going to continue to take feedback, but this is an attempt on our part to recognize that group as we move toward a different future state. But this is a very narrow group of individuals that would be targeted with this particular allowance. And I would also say attendant care is still allowable to be provided by someone else. Extraordinary care doesn't have to be met for an individual to receive attendant care. This is specific to an LRI providing that particular service.
I just have 2 quick questions if I can. Hopefully they'll be quick. The first is, you referenced the percentage of people who are being impacted as very narrow. Can you share what that percentage is?
You have some estimates, I think.
Yeah,
It's good to just have some context of how many people we're really talking about. If you have that off the top of your head, sorry.
I think that's difficult to say, to be honest with you, because when we talk about those families that have said we have complex care needs, sometimes that looks different depending on who's looking at it, right? So as a mom when I was a mom. Well, I still am a mom, but I'm mom with young children. Let me rephrase. I'm actually a grandma now, which is amazing, but that, you don't want to get me started. You know, in the throes of some of my oldest son's medical needs, which I know now, and I learned 5 years later, not that big of a deal. But when it was new to me, it was hard. And if anyone would have asked me, I would have said, absolutely, that's complex. It was, I didn't know that then. But again, I think we're probably talking, don't quote me. I would say maybe 10%.
Okay. And so 10%,
Probably
5 to 10. And really using like that definition of the medical complex needs, we're talking about 5% out of everybody who would need services based on the medical complexities is 5 to 10%.
No, I think what we are talking about, based on what we know now, please understand.
Oh,
I'm gonna say guesstimating, not even estimating.
Right.
So what we are saying, as an example, the number of individuals currently enrolled in health and wellness, knowing what we know, looking at their diagnosis, obviously we have information in the system that we would guesstimate somewhere around 5 to 10%. We don't know that for fact. You know, we're using, because we haven't reached out to every particular individual case manager to understand the circumstances. But that's what we're talking about, not 5% of people that meet that is of the, I don't know, 14,000 people that are enrolled in health and wellness, we would guesstimate 5 to 10% would likely fall in this category.
So we can estimate that it's lower for families, of course, given the criteria.
The criteria is different.
For them.
For to qualify for health and wellness versus. Because you're talking about.
Oh.
Yeah. So I 5 to 10% on health and wellness, maybe we're required to meet nursing facility level of care. Having those extraordinary needs, I would assume then would be less on feelings of work to the whole having to meet. I see it.
Yeah, I think we could probably project it would be maybe a little closer to the 5% than the 10%.
2 to 5%.
If we were making an educated guesstimate.
So my second question then, because based on what we have heard at the council and in this room, it sounds like some of the extraordinary circumstances that families are coping with or trying to cope with and need services and supports for relate more to behavioral health incidents when we're talking about health and safety. And is there a plan in place to move forward with a definition for extraordinary care for behavioral health needs?
Not at the moment.
Not at the moment.
But I would LRIs can still provide support through structured family caregiving.
I would also reiterate what Kelly mentioned earlier, that everything we're doing is on that path to waiver reset. So we'll learn about how this works. You know, our intent is to launch in the winter of this year, and we'll have data after that to see how that's working for the individuals. And I would just reiterate, some of the things that are on this slide is that the LRI providing attendant care or PAC in situations where the member has extraordinary care needs is defined as we just reviewed. We are still held to that needs to be in the best interest of the individual. So, you know, again, we'll have data after we implement and see how it goes. And that can inform future decisions, I think is the best.
Can I just add?
Yeah.
And I don't know how to start this, but I guess I do want to recognize that you guys could very easily say, we can't do this for everybody, so we're not going to do it for anybody. So I appreciate it that you are trying to do something for the some who really, really, really need this. Because That's big, right? We were extremely frustrated last year, so I appreciate more than you will ever know, you guys listening to those. I think we also, I'm not going to go through our public comments, right? We share the need of, there are some behavioral health issues there. The only thing I will add that's also my public comments is I do hope you get rid of the word continuous on the ventilator care. And there's a whole conversation around that. But again, thank you for the movement that you have made because that should not be overlooked. Rarely.
Yeah, it's very good. Approach. I know
Yes.
it always moves quickly and as fully as everyone would hope, but we are moving toward that end and goal, and we are listening.
Thank you. Absolutely.
2 questions. First of all, like SIB and PICA, would that be something that would not normally be performed? And how would you look at that as an extraordinary, okay. And then the other question I had is, and this is for a very small subsection, but individuals who are minors on the CIH, they are only, I'm guessing, only SFC can be used in this scenario, or could residential?
No.
Okay, so
It would not be.
okay,
That is not part of it. This is strictly to attendant care and PAC that we're talking about with this definition.
okay.
And last comment, and it's really just a comment, but just maybe a suggestion. I'm looking at something on CMS website about this, and one thing that it does that might be helpful for the public is also generally define what ordinary care is. And so, I mean, you're saying it's not just, I mean, you could literally take it from their website, but it's saying extraordinary care, but ordinary care. And I think it's hard sometimes, and it's really gonna be just some of the opposite language, but I think it might be helpful for the public to understand. Just to be reinforced with what ordinary is, and that's not you support it, it doesn't, it's not covering, waivers don't cover ordinary care, so I think it's just an important thing.
Sure.
I just want to go back to that one, the CIH with the minors, they're not, if they're on the CIH, then they're not eligible for attendant care, they're not eligible for PAC, so they're not eligible for any services on there, okay.
For by an LRI.
Okay.
Okay, got a couple examples here, just, we are running close on time, so, but can I have 5 more? Okay. Ask them,
I gave up.
You can. Oh, no. We'll have time at the end for questions, so I think we might eat into that a little bit, but we're answering questions, so. Just wanted to provide, next slide, please, a couple examples. I got one here for a 14-year-old. Again, with the continuous ventilator support, because that's the way the draft reads right now. Living at home with mom and grandma, receives skilled nursing through Medicaid PA or state plan, receives homebound educational services from the local school district, receives 20 hours a month of skilled respite through the health and wellness waiver. Based on his needs, he receives 30 hours a week of attendant care through the health and wellness waiver. Tom's mom provides the attendant care because he's been determined to meet the extraordinary care characteristics. Tom's mom can't provide skilled care when acting as the attendant care provider. We already talked about that, but just want to reinforce that. So when she goes to do, for example, anything with the ventilator, she's got to clock out. Then she can clock back in or clock out when the nurse arrives, or however that plays out. That isn't necessary in structured family care, right? Because it's a per diem service. So there isn't that clock in, clock out, all of that. So I just wanted to clarify that there is some, if you will, flexibility in that structured family care setting. Next slide, please. And then I included an example here with Carol and her husband. I don't think I gave him a name. But I didn't give mom a name either. So, but Carol's 35 and utilizes TPN for nutrition due to complex medical needs, lives at home with husband. receives skilled nursing. Based on her needs, she receives 40 hours a week of attendant care through the health and wellness waiver. Husband provides 20 hours of the attendant care. Because again, her needs meet that extraordinary care threshold. And then she's got a sister that provides 20 hours, just in this example. Again, reiterating, that skilled care can't be provided as, when they're acting as attendant care staff. Next
It
slide.
does seem a little, yeah, it does seem a little ironic to me that you have this definition that requires these skilled components, and those are the very components that you have to clock out for. Because what it sounds like to me is the extraordinary care is outside of those skilled components. So why would you have to clock out? Well,
State the service definition.
Yeah, that's the exact purpose of the.
Yeah.
And it's such a good point though. And I think it's one for us to address. When we're talking about the skilled need, that is to say the person
Mhm.
has those needs. It's not about what the service will be providing. So it's saying when an individual has these conditions, we find them to meet.
In need of
the-
extraordinary
in need of
care.
extraordinary care. Then it's in that instance, we would allow an LRI to provide attendant care. Attendant care is personal care, not skilled care. That is why, quite frankly, we stress that structured family caregiving for a family is actually less cumbersome, less burdensome. There aren't special requirements placed on an LRI to provide attendant care. These are the requirements for anyone that provides it. So those skilled needs, medication management, taking care, cannot be done while on the clock as a provider of attendant care, regardless of your relationship to the individual. Then you must clock out. The service has to be only those personal care needs, and it has to be active engagement. We really do direct people for structured family caregiving for that reason. It's a per diem. And family, as a family member, you can flow in and out of that naturally. You're allowed to do those things, and you're not on an hourly clock saying, I'm providing this attendant care.
It's a big deterrent for fraud too.
Yes.
Absolutely.
And it's difficult, and that is one of the things, quite honestly, that we looked at, in this and as we're moving forward. But I'm so sorry.
No, you're fine.
Should have let you.
No, you're fine. Absolutely fine. So just a quick, and this is very high level, on the feedback, but we have just at the very end of the public comment period, got a lot of feedback. On Monday, the 9th, we hadn't had very much. And then we got a lot more. So I tried to just kind of summarize the feedback overall. So in the feedback we've received thus far, and again, I want to stress, there will be other opportunities for that public comment. A lot of suggestions around other care needs that commenters would like to see added, including seizures, G-tubes, ostomy, catheter, dialysis. Some concerns were shared in a significant number of public comments that we received about the income needs of the families. And then support for allowance. We didn't have anyone offer public comment that said that LRIs should not be allowed to provide any paid care. So by and large, it was all supportive of LRIs being able to provide support. We received a lot of feedback about further defining the other comparable nursing services, Lexi, that you mentioned earlier. And it does appear from first glance at least the public comment we've received thus far, that there is a desire for us to literally spell out whatever might be considered as other comparable nursing services. So that's a broad view of the public comment. I know a lot of folks in here offered public comment, so please know if I didn't mention it, doesn't mean we didn't get it. It just means I'm trying to keep a, just do a high level summary.
I do have a question.
Sure.
Did you receive much feedback? I was very interested when Kim talked about the difference in continuous ventilator care and ventilator care, because if you need ventilator care, it's important. It's going to keep you breathing, right? I just wondered if there were a lot of comments about it, because to me, that would make sense, because there are individuals who might not need continuous, but need ongoing all night or during periods of time. So that would seem to make a lot of sense that that is still a necessary service. So I just wondered about comment.
I know at least two mentioned it specifically. There may be more, so don't quote me on the two, but I did see it more than once for sure. That people were suggesting we should consider something other than just continuous.
Thank you.
I know, Kelly, you kind of mentioned that, stressing the flexibility of structured family caregiving versus attendant care and that sort of thing. Correct me if I'm wrong. Structured family caregiving is not available on the family supports waiver, correct? So when you're talking about extraordinary care, so it would just be PACS. So is there any consideration for families who might fall into that 2 to 5% to offer structured family caregiving if they meet this extraordinary definition under the family supports waiver, considering the kind of the back and forth of clocking in, clocking out, all of that, that would have to happen with PAC.
So I would say there's nothing that we're discussing with that right now. Just the family support waiver is, as you know, it's a capped waiver and doesn't offer that what we would traditionally call that residential service. But I think that's good. Again, good information for as we think about waiver reset down the road, when we would be looking at all of our waivers and what the needs are of individuals and how we can design a system that's sustainable and addresses the needs and also supports people in being included and engaged in their community.
I think the question that I had asked earlier about the CAH, I think that gets to it, is that if I have a child that's on FSW, I can provide PAC services, but if they were on the CIH, I can't provide them any services at all.
Correct. A parent of a minor.
Right.
Correct.
So I don't know, I'm just saying the access seems a little wonky that on one you can and the other one you can't.
Yeah, I appreciate the feedback. Okay. You're correct. There is a difference there. We lost.
All right, I know. I think we're gonna take our break.
Oh,
That was my idea of, but you're good. You finished that part. Yeah. So at 11, that clock is wrong, so don't look at that. At 11:35 and we'll get started. Lexi, do you want to say anything about, Lexi sent me this video. Do you want to share anything about it before I hit play?
Yes, definitely. So in college, I did a practice of outside the box, and this video was part of me and my classmates training, part of our orientation. It was like kind of at the beginning of our orientation. And I think it just speaks volumes to just all the potential that our community as people with IDD or other disabilities have. It just speaks volumes to, our potential, our ability to be as independent as possible in our own way, and just to live the life of any other adult that didn't have a disability. So
awesome. Okay, I'm gonna hit play and cross fingers this works.
History. People with physical and mental disabilities have been abandoned at birth, banished from society, used as court jesters, drowned and burned during the Inquisition, gassed in Nazi Germany, and still continue to be segregated, institutionalized, tortured in the name of behavior management. abused, raped, euthanized, and murdered. Now, for the first time, people with disabilities are taking their rightful place as fully contributing citizens. The danger is that we will respond with remediation and benevolence rather than equity and respect. And so we offer you a Credo for support.
Do not see my disability as the problem. Recognize that my disability is an attribute.
Do not see my disability as a deficit. It is you who see me as deviant and helpless.
Do not try to fix me because I am not broken. Support me, I can make my own contribution to the community in my own way. Do not see me this way. I am your fellow citizen. See me as your neighbor. Remember, none of us can be self-sufficient.
Do not try to modify my behavior. Be still and listen. What you define as inappropriate may be my attempt to communicate with you in the only way that I can.
Do not try to change me. You have no right. Help me know what I want to know.
Do not hide your uncertainty behind professional distance. Be a person who listens and does not take away my struggle from me by trying to make it all better.
Do not use theories and strategies on me. Be with me, and when we struggle with each other, let that give rise to self-reflection.
Do not try to control me. I have a right to my power as a person. What you call non-compliance or manipulation may actually be the only way I can exert some control over my life.
Do not teach me to be obedient, submissive, and polite. I need to feel entitled to say no if I am to protect myself.
Do not be charitable towards me. The last thing the world needs is another Jerry Lewis. Be my ally against those who exploit me for their own gratification.
Do not try to be my friend. Get to know me. We may become friends.
Do not help me even if it makes you feel good. Ask me if I need your help. Let me show you how you can best assist me.
Do not admire me. A desire to live a full life does not warrant adoration. Respect me, for respect presumes equity.
Do not tell, correct, listen, support, and follow.
Do not work on me. Work with me.
Do not work on me. Work with you. Do not work on me.
This video is dedicated to the memory of Tracy.
Thanks, Lexi. I love that video. So thank you for sharing that. I appreciate it. Okay, Holly, if you want to go ahead, I'm gonna work on, if you want to start, I'm gonna work on getting these.
Sure. Back to you.
See how they look.
Okay, so when Jess gets the slide back up, we're gonna take some more time to talk through some of the proposed items for inclusion in waiver amendments that would be effective in winter 2025. the end of December is what we're looking at. So first is self-direction. So very happy to tell everyone that we will be updating that self-direction model. There are 3 services on each of the waivers that individuals may self-direct. On the family support waiver, that is the participant assistance and care, respite, and workplace assistance. On the CIH waiver, it's residential have-in support, the hourly respite and workplace assistance. Health and wellness, the services would be attendant care, respite, and home and community assistance. On the TBI waiver, attendant care, respite, and home and community assistance. There it is. And then I included the Indiana Pathways for Aging, which is the same as the health and wellness and TBI waivers. So we're really excited. Like, can't tell you how excited we are about this. This is something we've heard for a long time that individuals are interested in and would like to be able to would like to have as an option. So I'm not going to go into a lot of details about it just because of time constraints, but we are just really, really excited to offer this, particularly for individuals on the family support and CIH waiver who have never had access to self-direction or self-directed services. So next slide. Another item that we are proposing in the set of amendments is revision to the service definition for integrated healthcare coordination. This is a service on the health and wellness, traumatic brain injury, and pathways for aging waiver. We are going to be clarifying in that service definition that there can be no duplication of service, which should be that's a CMS rule, but no duplication of service when an individual has access to care coordination via another source, such as managed care and DSNP, dual special needs plans. Again, that would really just pertain to the Indiana Pathways for Aging and the Health and Wellness waiver, primarily that Pathways for Aging and the managed care piece. Then we're also happy to share, next slide, please, that we have or are moving forward with adding a new service, benefits counseling, to the family support, CIH, health and wellness, and TBI waivers. So we're very excited to be able to add that service in support of our overall employment transformation plan, and again, thinking about our journey towards that waiver reset and the importance of employment. Yes, Lexi.
Would somebody be able to use something that wouldn't go towards their budget, like WIPA, if they didn't want to use their budget on benefits counseling?
So ask me that again, Lexi, I'm sorry.
So I got my benefits counseling through VR, and they said once I wasn't with VR, I could get it through WIPA. The WIPA does it for free.
Yes.
Yeah.
So would they be able to not like, I guess I'm trying to understand like why would somebody use waiver dollars for something they could get from like WIPA?
No, I think that is an excellent question, Lexi. And it is something that we are making available. People don't have to use it. Certainly, we want people to use existing resources. If there is a free service out there that's available to people in the community, people receiving HCBS services should have access to that too. So absolutely. And there would be this would be available for those who can't access it through other means. Great question. And thank you for pointing that out. We're also going to be adding extended services to the health and wellness waiver. That particular waiver has not had employment services. So we are really glad to be able to add that service for individuals on the health and wellness waiver. We're also updating the supported employment definition on the traumatic brain injury waiver. That definition hasn't really been touched in a while. So we're aligning it with the extended services definition for the same service on the family support and CIH waivers. And then the last item is something we have talked about as part of that broader employment transformation plan, and that is discontinuing enrollment in facility-based pre-vocational services that will impact the family support and the CIH waivers. Okay, so I'm gonna walk through this next slide about attendant care and PAC. I do want to note, we are still reviewing what I'm about to present, so there may be some additional modifications. But want to make sure and walk through this with this group. So on attendant care, the proposal that we, again, are looking at still, and there may be some modifications, and we would keep you up to date on that, is that a paid family caregiver, non-LRI, on the health and wellness, TBI, and pathways waivers could provide up to 40 hours a week of attendant care per participant. So let me say that again, and in a little bit of a different way. An individual receiving waiver services on the health and wellness, TBI, pathways waivers could receive up to 40 hours a week of attendant care from a family member. It would be 40 hours a week per waiver participant. Okay, just want to make sure I explain that. And then an individual could receive up to 40 hours per week of attendant care per participant by an LRI when the extraordinary care definition, right, when that member, that participant has met that extraordinary care threshold that we talked about earlier. Again, that impacts health and wellness, TBI, and pathways.
So do these limitations, these 40 hours kind of across the board, they imply that some people have been exceeding that, and so if their budget had it, maybe they were exceeding it, and now you all are putting in a 40-hour limit. Is that?
So the LRIs right now can't provide the attendant care, right? So we're saying when we launch that,
Okay.
Based on that extraordinary care, that they could get up to 40 hours from an LRI. I do want to note that I say up to 40 hours because if there is not a demonstrated documented need for 40 hours, it doesn't matter who's providing it, right? It would be, based on the need. Now ask your question again. I think
I'm seeing, I mean, you're calling this service limits and they're all 40 hours. So one must assume that there's some people who are exceeding this 40 hours, like saying, well, I have say on the family supports waiver, I have 27,000 hours or whatever. And I'm going to try to throw that all into PAC. And since I'm the family member, I'm using it. Is the purpose of these waiver amendments with the limitations because some people have been exceeding 40 hours?
So our service is
Yes.
yeah. So a couple things I wanna note. The service plans that on the health and wellness and TBI waivers, we being BEADS, reviews the vast majority of those, almost all of those service plans to the tune of about 120 a day that come in. So we look at those service plans for a variety of reasons, but for one reason is to make sure that the level of service being requested or authorized is commensurate with the need, the documented need. Today, we don't have great data on the health and wellness waiver about who is actually providing that attendant care. And right now, go ahead, were you gonna say something? Oh. Okay, that's fine, you can interrupt anytime. So today, there is not a limit per se on family members providing attendant care on the health and wellness and TBI waivers or pathways waiver for that matter. So this would be putting a 40-hour from a family. Were you gonna add to it?
No, I think that really covers it, and just for those that don't know, there are already limitations on the hours per week that family members can provide on the CIA.
Yes.
Right, those have been in place for some time, but Holly's point, those don't exist at all now. The health and wellness.
Or TBI.
And pathways and TBI. And this really is again, looking at, we don't know now, but we do know. Prior, to some of the changes that were made in January 2024. We had instances where family members were on the health and wellness and pathways. What became that, we're providing 80, 90 plus hours per week, and perhaps one individual is doing that. So there's concerns, obviously, just around Department of Labor, quality of care, right? Is the individual, is that truly the individual's choice? Is it being done for the individual? So trying to recognize individuals have the right to choose, but we also want to make sure that we're putting appropriate protections in place. So we are still looking at this because we want to make sure that what we do is appropriate all the way around. That we're supporting that, but also ensuring the rights of the individuals that are supported.
Thanks, Kelly. So I want to make sure I'm reading this right, Holly. So it's 40 hours. I'm looking at the third bullet. So 40 hours, period, whether it's by a paid family caregiver or an LRI, it's 40 hours total.
Correct.
Thank you.
That's correct. I just had not gotten there yet, Katie, but thank you. No need to be sorry, but yes, that is correct. It would be a total of 40.
And you kind of took that for a couple of us, for me, how does this relate to people who are a family member, a caregiver, or right? Do they have a training requirement? They're just thinking about how this connects to our conversation about training. And this is more my naivete than anything. And then how does this connect to the self-direction aspect that's being proposed to? So can you tell me, is there that ties into these things?
There absolutely are. So for anyone to provide, for example, attendant care, whether it's an LRI or another family member or Holly, providing that, I would still have to be trained.
Yeah, do that training.
Yes.
Okay.
Beginning July.
Yeah.
Or January, sorry. Yes, that would still be required because I still have to work for a provider.
For the CIH and the FS.
For the CIH and the FS. Oh, thank you. Yes.
Yeah.
For the health and wellness and TBI, it is not required, but there are training requirements for attendant care.
So getting that credential is gonna be, I'm just trying to use the terminology we use for that person will have to get that credential to deliver these services.
To deliver packets. So thank you, Kathy, for clarifying
Yeah,
that.
correct.
Now, for the attendant care, again, there are requirements that providers have today, much like providers have requirements today for
They got it all.
staff providing that. But yes, they would still have to be trained as if they were sort of.
And then the self-directed ask, how does this tie into self-directed?
So, no, I think that's another good question. So LRIs would not be able to provide support through self-direction. Because they could essentially be self-referring. So for example, and CMS has clear guidance about self-direction and not self-referring. So in self-direction, as we plan to roll that out in the winter, self-direction would have what we call budget authority. Okay, so they would be able, self-directed service, they would be able to decide, for example, how much PAC or how much attendant care they can purchase with that amount of money, right? Which would be the same, essentially the same as someone not self-directing minus 10% because of the FMS that we have to cover. So if an LRI, for example, says I want to self-direct attendant care for my child, right? They're really deciding that they're gonna pay themselves and how much they're gonna pay themselves within the limits. So we do not intend for LRIs to be able to provide that self-directed.
So.
Can you say it a little better? That's fine.
Yeah. So they can't be paid to provide that service, but they can still direct.
I'm sorry. Thank you.
So,
That's fine.
parents of my child can still say, I want to participate in self-directed attendant care and I want to hire grandma, right, to be my staff for my child. But I can't pay myself. I can't act as the employer and as the employee.
Thank you for clarifying that. Yeah. Thank you.
But a spouse who's an LRI, under self-direction, the person can say, I want to hire my spouse.
No,
No.
because spouse is that part of that definition of LRI.
But even though the spouse wouldn't be directing, the person is still self-directing.
But they would still be an LRI. All right. Oh, no, go back just for a second. I'll just say here, that PAC would work similarly. Of course, the 40 hours a week with the FSW being a capped waiver, they're not gonna hit 40, but just the way it's going to be written in the waiver. And then the residential habilitation and support on the CIH and TBI waiver. As it exists today, and again, this is something we are still looking at, has a 40-hour-a-week limit per family member. And this proposed item would say it is 40 hours a week per participant by a family member. Next slide. And then we are proposing to limit the amount of music therapy an individual may receive on that family support or CIH waiver to 6 hours a month. As well as the recreational rec therapy to 6 hours a month. Did you want to go ahead?
You go right ahead
Okay.
first.
I was going to provide a little more context. So we have seen.
It wasn't subtle, was it?
Both of these services, an upward trend in utilization with music therapy. We've seen some issues with prep time, digging into budgets in lieu of the in-person services and some carryover from COVID flexibilities where individuals and families are now traveling to a location to access that service as opposed to that service being provided in their home. So we feel like families are getting, at least in some situations, less for what they were getting before before COVID. We also think this is a way to, help individuals and families on the FS stretch their dollars a little more. And have that for other services where appropriate. We've also seen rec therapy really increase in utilization in the last few years. So this is just something that we're proposing. Kim, you had a question.
Well, and you answered it a little bit because I was going to ask how you determined 6 hours, but it sounds like you do have some data that you looked at just to kind of determine that. I think what we hear from families is because there is such a lack of DSPs, right, in other areas, that in order for somebody to live a good life, right, instead of sitting at home, they have access to some therapies rather than no therapies or no services. So, I don't know, I guess all of that is just food for thought in the sense of, we've come so far, I think, in the state of Indiana to really helping people live a good life that I think some of these, utilization limits, I think is just hard to get through because I think we are just going to see people regress and stay at home and not get anything rather than get something that they enjoyed and got some good use out of.
Yeah, and this is going to mirror some of my comments later when we're talking about behavior support, but with music therapy and recreational therapy, as well as behavior support, there are a lot of people in the state of Indiana who get a family supports waiver. They're offered a menu of options. And then when going through and starting to discuss choice lists, it's like, oh, you can't really get a PAC provider. Nobody's going to give you respite unless it's a next door neighbor or your family member, but you can get these other supports. And it facilitates community integration, lots of other really positive goals that these people have. It concerns me that these limits are being put in place for families who don't really have other options. Um, I understand it's like, well, if it's more than their support needs, but really, at what point does music therapy or recreational therapy, and in many cases, behavior support, hit some imaginary cap when the person doesn't have other things going on in their lives? I see this as kind of a way to limit family choice, and I think that it's unfortunate.
Yeah.
Lexi, I'm sorry, I didn't.
So it's okay, it's just kind of, just in addition to that is that, I think what's important is just like the person-centeredness of kind of letting the individual, to the best of our abilities, choose what we want and where we want in our budget, and just ensuring that we have like the best understanding. Because, ultimately, if we're allotted a certain amount of budget, I think the flexibility of the services should be allowed, because I mean, we talk about choice all the time and dignity of risk, and I feel like, that's something that should be available to us, is to be able to have the choice and dignity of risk of, what might be a good option and not, just to be able to like use the waiver to the best of our abilities in our community. Just all that, basically saying what was already kind of said.
I have two concerns. One of them is a lot of the children use a lot of their hours during the summer, and that if it's 6 per month, then it doesn't necessarily spread that way, so that's a concern. And I've also seen a lot of folks who, for the first time may have gone to the Pacers game or anything like that, and that takes 6 hours, to come downtown and go, and then it's bust, that's it for the month. And having that freedom has been very, it's been a big win for a lot of our individuals.
So that 6 is 6,666. It's not 6 times 12, just that total bucket.
No, actually, it's 6 a month or the annual amount. So there would be the flexibility to use that in the summer.
Thank you.
Yeah. So you can.
Yeah, you can bundle, yeah, you
Yes.
can
Yes.
save it up.
Yes.
Mhm. I guess I'll just add a couple of other considerations for this group. I think the theme that you may be picking up in today's meeting is that we do not have a sustainable waiver system.
We know that.
And I think you all know these are steps we're having to take to preserve, to the best of our ability, the existing structure until we can move to a place of redesigning and resetting our waivers. Recreational therapy, the costs for that service have increased over 50% in the last 3 years. If we're using those types of services to augment or fill someone's day because they don't feel like they have other options, unfortunately, it is not the intent and purpose of that service to do that. So we are having to put some additional guardrails in place. One, to preserve, but also other people may now be able to access music therapy who weren't able to access it before because someone was using half or the entirety of their waiver budget on that and maybe another service. So we have to think about how people are utilizing these particular types of services and supports and how they were intended to be used when we developed them. And we're just seeing a shift in that trend. So I think Holly's kind of sentiments about putting some of these limits in place are really intended, again, to kind of shore up where we're seeing some of those dynamics play out, but also to get us to a place where we can say, what should our service system, what new reality financially we're living in, and what does that service system need to look like so that we can build a new, more sustainable model.
Hey, Holly, sorry, I'm standing because my legs hurt. I'm gonna move you. I don't want to stop that conversation, but there's quite a bit more information you wanted to share, so.
Can we put it on a parking lot conversation for the future?
Yeah. Yeah, for sure. Yeah, there'll be more conversation. I mean, this is, but I don't want to, there's other things I think you wanted to share too that.
Yes. To add that, I think Kathy was most well taken, we really do need to see where need exists, and so if we are using services to augment what isn't available, we need to be aware of that and push the resources there. I will say part of the rollout and self-direction, to your point, if it's the fact that you can't attract or recruit a direct support professional, self-direction is an option, you can use this, the budget doesn't change. If you have to pay a little more, which would still be less than music therapy cost or recreational therapy cost to get a DSP to do those things, there are avenues, so we are trying to look at the whole as we work within the confines in our current fiscal situation.
Thank you. Just want to mention again, and we've talked about this before, that we are looking at launching new tools to assess ICFID level of care. Again, in the winter, those are also from the Entri suite of tools. So we will use the early years 403, what's called the CHIME, Child, Youth, Mental Health, Developmental Disability. Assessment for the 14 to 17, and then the Entri intellectual disability for 18 and up. So we will be, again, moving to that tool. We have needed to do this for a number of years. As you all know, our current tool is homegrown. And so we'll be moving to these standardized tools. I do want to know quickly, BEAD staff will continue to do those initial level of care assessments for ICFID, and the case managers will continue to do the annuals as they are done today. Okay, next slide is about some proposed changes to our behavior support services. So I'm going to try to do just a quick summary, and I'm not going to read all of this to you, but at the end of the day, what we have had is a lot of feedback, as well as work through some of our innovation pilot projects that have brought us to what we're proposing here, which is that we would take the model we have today of essentially behavior support services that are provided on a regular basis and level 1, and move that to 3 direct service components. Would you go ahead and move up? I think it's probably
that one.
Go ahead and go one more. 3 direct components that individual.
Holly, I don't think it's.
No, it's that one.
Oh, I'm sorry. Oh,
Yeah.
There's like a lag when I hit it.
You're fine. I'm sorry. Moving to 3 direct components that individuals who have a need for behavior support services would be able to choose from. One is consultation. So that would be, they just want quite literally a consultation, right? They don't feel like there's a need for that ongoing service. So a consultation would be something someone could just choose to have that. I see this as probably being a good option for some individuals or children particularly, that maybe the parents just are interested in that consultation. The other direct component would be a functional behavioral assessment, which again would be something someone could choose. We won't require that happen yearly. in this new model. But it's something that someone could opt for and just purchase essentially with the waiver that service. I should go back to the consultation. So with you'll see the one column that says budget maximums. We are looking at an overall limit to behavior support services as well. And individuals, again, could choose consultation, functional behavioral assessment, or the comprehensive behavioral supports, which is more like what you see today, more like that model that we have today, where it's an ongoing service. All of those together would not be able to exceed 12 hours a month or 144 hours per year. So there would be some limitations there, but there is a lot more flexibility for individuals who are seeking this service. Today, if you want behavior support services, by and large, you're signing up for that ongoing service, not someone to come in and do an assessment and then provide you with some information as a result of that assessment or that consultation, and then in that service. That's just not the way that the service today is structured. So we are looking at reconfiguring that. We will continue the clinical supervision requirement that is the indirect service. We are looking at or proposing that would be provided either by the HCSP, or we have broadened that a little bit to include licensed family and family therapist. I'm not going to get these right. Licensed mental health counselor, licensed marriage and family therapist, or an LCSW, licensed clinical social worker. So we are looking at broadening that definition. Thank you. And that clinical supervision can be chosen, but won't be required unless there is restrictive measures, such as, just as an example, locks on the refrigerator, for example. So this is a good or a reconfiguration of what we do today to offer more options for individuals seeking that service or in need of that service. Again, it does also include limits. Yes.
This is really a good move forward. It looks and sounds very good, especially some of the things that we hear about families needing that kind of wraparound level of support that you would see in system of care. Do you see that kind of momentum towards, if more folks are aware that this is an option for the evaluation process, that there would be an opportunity for kind of that wrap around supports for the family, not just the therapy supports for the individual, but also extended out to the family members?
So I think behavior support even today, right? And we see this a lot when we're looking at situations, is really that behavior support provider today should be supporting that family and how to address the needs or behavioral needs of the individual. I do think this particular model supports that even more so in a lot of ways. But I think it just adds some flexibility that today individuals and families just don't have.
So Holly, I'm sure you can imagine I have a lot of questions and a lot of, so first of all, I want to acknowledge that I am aware that there were some proposals that were much more draconian than this, and I appreciate it not being just a completely flattening of behavior support, because I do think it's a valuable service that a lot of people provide. I do find it a little bit disappointing that the whole process kind of got to this point, and now as an advisory council, there's a lot of talent around this room, a lot of experience, and now we're basically being informed what's basically been decided. And I understand that it's still draft. I do find it a little bit disappointing. I mean, I'm here as the representative for the Indiana Association of Behavior Consultants. There are over 600 members and all of the individuals that they serve. And we've repeatedly asked to have a seat at that table to help you. I mean, we're not going to be the decision maker, but we could offer a lot of support. And that has not really happened. And I'm disappointed by that. So as far as some questions go, with these different components, let's say somebody decides they want an FBA and they get the FBA and then they think, well, I want traditional behavior support. It seems to me like it shouldn't be any problem to really switch because really the limitation is not. Okay.
Yeah.
Second,
Let me just
sure.
clarify that too. That is fine, right? People can choose.
Sure.
Can't have those two at the same time,
I understand that.
but you know, in the same time period or concurrently, but yes.
Yeah, and the rates are all the same.
The rates are not
You
changing.
already went over that with me separately. As far as the clinical supervision, I would like to point out that it's very, very rare for somebody to get 12 hours. It's really 12 units. And that's probably something, because it's really 4 times as much as most people ever get. One thing that I wanted to ask about with the licensed people who are not currently HSPPs. I believe that there was also an experiential component. Has that been dropped?
No, that is there as well.
Is
There's
it
still
is it
experience.
5 years of
Believe it's 5
experience,
years,
or is it
yes.
5 years experience supervising?
I'll check that and get back.
Okay,
I
that,
don't
and
wanna-
that's
I
that's
don't
fine.
wanna, give you incorrect information.
Okay, and that's fine. That's fine. I think that to me, when I look at all this stuff, I get it. I mean, I've been here for this 2 hours and I understand that you're trying to do the best that you can. And I'm sure I speak for everybody. We respect that and we're appreciative. I do think that there are times that decisions are made that are poor decisions. And I think that it's something to consider or to reconsider. And that is to administratively decide that psychotropic medication is not a restrictive measure has giant ramifications. And if the idea is we can just loosen up the rules so that we don't have as much supervision required, I understand that. Maybe that's the point. But there really are very few restrictions that are more restrictive than giving somebody a medication to control their behavior. And at this point, what it kind of is saying is, well, you don't need to have supervision unless they're locked cabinets. Keep in mind, particularly licensed psychologists are very well trained in like, what are the outcomes of psychotropic medication? We routinely use this for in supervision to talk to our VCs. I know that there has been kind of this idea that there aren't enough HSPPs out there. I would just simply say that's not true. I mean, as you all know from the IPP project that I did, I have a group of about 30 that I regularly interact with. I've notified 2 months ago, maybe even 3 months ago, provider relations, that if you have people who, BCs who are looking for supervisors, I know people who will provide that support. I do it myself, but it's not just about funneling everything to me. I have multiple people. And so I don't quite understand the rationale behind, oh, we don't have enough of them, so we're going to expand it beyond that. Last comment that's probably the most relevant to the medication, the psychotropic medication, not whether it is or isn't a restrictive measure. As you know, for decades, behavior support providers have been required to write not only what are the psychotropic medications within a behavior support plan, but what's a medication reduction plan. So is that also going away for behavior support providers if we're going to say that it's not a restrictive measure? I mean, these are ramifications. And I'll tell you, the biggest ramification is polypharmacy. You're going to see a lot more psychiatrists who don't, if all of a sudden if it's not a restriction, does it not need to go through the Human Rights Committee? And if it doesn't go, and I'm not saying human rights committees, and you and I both know this.
Yeah.
Human rights committees, sometimes they don't really know a lot about medication and they may just be a rubber stamp. But you know what? If they see 10, they might ask a question, and if they're seeing it constantly and then they see somebody with 3 medications and they see somebody with 14, that might be, it's at least a stopgap of possibly preventing these issues. So I would really encourage you to drop that whole idea of psychotropic medication is not a restriction, because it's probably one of the biggest ones in our system.
And please know, I'm not saying it's not a restriction. What I'm saying is it wouldn't be considered a reason to have that clinical.
Right, which is.
Probably the most.
And I hear you, and
Right.
and just acknowledging, I
okay.
don't want anyone to
Sure.
walk out of here thinking that we're saying psychotropic meds are not a restriction.
Okay, but if that's the case, then it doesn't make sense that a behavior support provider who is on the hook for medication reduction plan, is on the hook for writing this into the behavior support plan, all of a sudden doesn't need to be supervised over it. Even if it's somebody, just two clinicians casing, staffing a case, you might come up with ideas about like, oh, okay, for example, Depakote and Zyprexa, commonly prescribed medications. They also really promote hunger in people. So what if you have a person who has food seeking behavior? If you take this out of the equation, they're simply not going to be, that's not going to be something that comes up in most people's plans. It's a really important part of clinical supervision, is talking about those side effects and how they actually affect the person's behavior, particularly if it's the key behavior that a person exhibits. I've had clients in ESN homes who had incredible food-driven behavior, and through supervision, we talked to the psychiatrist and got, alternative medications prescribed for this specific reason. So I'd invite you to reconsider that as a reason to be, for supervision.
Yes.
I just want to second everything he just said, coming from somebody who's been on the meds we're talking about for the majority of my life, and I received behavior management. And when I was on the age and disabled waiver, and long before that, I was completely sedated on my meds. Now that I receive behavior management and with the way things are really, going, we're trying to get me to be like the least sedated I can possibly be. And I spent like over a decade just completely out of it, so.
Appreciate that. Appreciate you sharing that.
I would also like to revisit just the HSPP thing, if I could add 2 cents on that. I'm
Sure.
100% agreement that the majority of the licensure levels listed here as examples really have very limited experience in our field. And I like that there may be a component that they have some experience, but I would definitely say that has to be in like in our population. If we're gonna say experience, it doesn't really matter if I'm a, family therapist. If I've never interfaced with this population, my experience doesn't matter. I mean, not that it doesn't matter, I don't know. Absolutely. That's not experience in our That's not experience in our field. My apologies.
No, that's fine. Thanks, Amy. I'm gonna go ahead if we can keep going, because we've got 6 minutes left. So just a few other things wanted to mention here about some other things you will see in the waiver amendments. Just some aligning of the money follows the person reserve capacity on those waivers with our money follows the person programs. Unifying the definition of structured family caregiving. CMS told us we needed to do this in 2024 across all of our waivers. So we are going to be doing that as well. One thing that is important for the TBI waiver is today and historically, there has not been the ability to share residential HAB services on the TBI waiver, which has really provided less options for individuals on the TBI waiver to share a living setting outside the family home. So we are very happy to be able to say that they will be able to do that with this set of amendments when we go to implement that. So that will open up some options for people. We'll also be aligning to one category of adult day service provider. That is not anything that will be impactful for individuals. That is kind of a catch up to some practice that we have. Next slide, please. We are combining home modification assessment again at the direction of CMS. Updating emergency placement priorities. That is a catch up to some language that was changed in legislatively. Alignment of quality improvement measures, revisions to some service definitions. Do want to note we are in those service definitions, a couple of the things that we are doing is making some changes to the required documentation for attendant care and PAC. So attendant care today is like one note for a day, even though it's an hour of service. PAC is one note per shift, which has been that way for quite some time, back when there were 8-hour shifts or less. So we are changing that to better reflect the units and going to be requiring an hourly documentation for PAC and hourly for attendant care, even though that's a 15-minute unit, we're gonna go with hourly documentation there as well. And we don't need a book, but there needs to be some documentation to support the abilities. Reflecting dollar limits for certain services. This is where our rate reviews that we did some time ago, where the waivers, we had not caught them up in a couple spots. We had a couple misses. So the rates are in place and providers are billing those, but the waiver documents didn't reflect that in a couple spots. So we're just gonna fix that. And then some clarification of service definitions and updating the description of selection of entrance to the waiver. Next slide. All right, well, we talked about waiver reset kind of throughout the day today. Because I think, and I guess in closing, I would just reiterate, everything we're doing today is meant to support building that sustainable system for the people we support today and the people we'll be supporting in the future.
So given that, and I realized that there were a lot of different components discussed today. The thing that was probably reconfigured, you added some limits to like recreational therapy but the thing that was changed the most is behavior support. Is it safe to say the waiver reset for behavior support is now what we're accomplishing now, or in the future, is there a decent chance that this is gonna get reshuffled right back into the deck?
You actually asked, but I was going to say as we think about waiver reset and to your comments. This isn't the end. We have been focused on, and you know this, you and I have had conversations, right? On behavioral support, behavior management, all those things. There are a lot of good service providers out there and a lot of good things going on. And yet we are not accomplishing what it is we desire. We hear it, it's the biggest piece. So it's not the end. And when you said you and the association would like to see you at the table, we will be inviting people to the table as we move toward that targeted 2027 reset. We hope to be putting some things forth soon to start gathering that. But we know we have people with much more intensive need than we've historically supported in community settings. And it's not just in this state, we've been talking about it nationally. So we really need to look at how might we do this better. So yes, Jim, we want you and others at the table, and it's not the end. But there were some things that we needed to do now, to your point.
Well, if you want any assistance in rewriting definitions, there are a lot of things that I can be of support for, and it's obviously free of charge because I'm on your advisory council. I'd be happy to help figure out ways to make more sense and align with what we're actually doing. And that's just always an open invitation, as you know.
And so sorry you all had to listen to that was like 3 hours. I'm gonna. I never lose my voice.
Yeah.
Sean was.
All right, thank you guys. Next meeting, August 20th, here at the Government Center. Thank you.
Like my husband's desire for me to.